Hello, and thank you everyone for joining us for our next installment of the IACH for Pharmacists webinar. We're really excited today to have with us guest Sarah Profitt. She is a malignant hematology clinical pharmacy specialist at Vanderbilt University Medical Center in Nashville, Tennessee. And we're really excited to have her today here to talk to us about bispecific antibodies. And this is something she's spoken on quite a bit and has a lot of experience with, not only in her clinical practice, but also, educating other pharmacists on the use of these therapies in practice. So thank you so much, Sarah, for being here. And we're excited to hear what you have to tell us.
Thanks, Katie. Appreciate the introduction, and thank you to IACH for having me. It's really exciting to be here with colleagues all over the world. So excited to share some information and chat with colleagues from wherever you're tuning in. So thanks so much again. Bispecific antibodies have been a really hot topic for us here in our practice in Nashville, Tennessee for the last 12 to 18 months, and I'm sure a big part of your conversations in your practice as well. So very timely topic for us today. We're going to be specifically talking about bispecifics in relapse and refractory non-Hodgkin lymphomas. We know there are some bispecifics approved in other disease areas, and I'll briefly mention those, but we're going to be focusing in on lymphoma today. So let's get started. I do have some disclosures that I'll briefly share with you here. And next, I'd like to share our educational objectives, and that is to summarize efficacy and safety data for bispecific antibodies for the treatment of relapse and refractory non-Hodgkin lymphomas, to explore clinical and logistical challenges that impact the use of bispecific antibodies, and finally, to investigate methods for pharmacists to integrate into multidisciplinary initiatives, improve the safe and effective use of bispecifics. So briefly, let's level set on non-Hodgkin lymphomas. We know this is a spectrum of disease subtypes that range from aggressive, like Burkitt and high-grade B-cell lymphoma, to more indolent subtypes like follicular. The median age at diagnosis is 68 years. And a little bit of demographic data for those of us in the United States, an estimated 80,000 new cases in 2024, which represents 4% of all new cancer cases. And there are an estimated 20,000 deaths for this year in 2024, which represent 3.3% of all cancer deaths. The 5-year relative survival for non-Hodgkin lymphomas as an umbrella diagnosis is 74%. And we'll focus in a little bit on some subtypes next. So the first subtype is diffuse large B-cell lymphoma. So this is the most common subtype of non-Hodgkin lymphoma. The bulk of our non-Hodgkin patients have DLBCL. And we know that unfortunately, after first-line chemoimmunotherapy, up to 40% of those patients unfortunately relapse or have disease that's refractory to first-line chemotherapy. There are a multitude of options once patients fail first-line chemoimmunotherapy that you can see on the slide, trying chemotherapy again, things like auto transplant, targeted oral agents, and ADCs. Unfortunately, not all patients are transplant candidates, and unfortunately, long-term remissions are still not possible for all of those patients. And similarly for CAR-T, which definitely changed the treatment paradigm for relapsed and refractory large cell lymphoma, not everyone's a candidate for CAR-T, and unfortunately, it can't provide durable remissions for all patients. So this is a huge continued unmet need that bispecific antibodies have really impacted. So excited to talk more about that. And then beyond just diffuse large B-cell lymphoma, indolent lymphomas, indolent subtypes of non-Hodgkin's, make up about 1/3 of all non-Hodgkin lymphomas. And despite the term indolent, patients unfortunately are subject to repeated relapses, short durations of remission, and despite what looks like on this screen, a lot of options, several of these are associated with low overall response rates, short durations of remission, and again, bispecifics have really been an exciting, promising option for patients with indolent lymphomas that have relapse or refractory disease. The most common type of indolent non-Hodgkin lymphoma is follicular lymphoma. So we're going to be talking about follicular lymphoma, and you know why, because we have a bispecific antibody approved for relapsed or refractory follicular lymphoma. So we've been talking a lot so far about bispecific antibodies. Let's talk about what they are and what they do briefly. Bispecific is exactly what it sounds like. So these are monoclonal antibodies that have been engineered to have two targets instead of just one. So bispecific meaning two targets. In the case of T-cell engaging bispecific antibodies, the ones that we're going to be talking about today, one of those targets is CD3 on a patient's own T-cells. And the other one is a tumor-specific antigen. So depending on the disease that we're talking about, we can have a multitude of tumor-specific antigens for bispecific antibodies. And what this product does is bring the patient's own T cells in close proximity to the target cancer cell, in this case, the lymphoma cell, the malignant B cell. And we'll talk a little bit about the tumor-specific antigen for lymphoma in a second, but this product brings the T cells in close proximity to the cancer cell. And these T cells actually don't require co-stimulation. They don't require MHC. They actually are immediately stimulated. They can recruit other T cells to the local compartment. They release granzymes, and they form a pore in the cell membrane of the cancer cell, causing cell lysis. So this is a really efficient and sophisticated mechanism to hopefully mitigate off-target toxicity that we have traditionally seen with cytotoxic chemotherapy, whereas this is a really targeted immunotherapy approach. So I alluded to T-cell engaging bispecific antibodies in other disease areas besides lymphoma. There are several FDA-approved products here in the United States for other heme malignancies. So you can see that on this slide. Blinatumomab has been approved for acute lymphoblastic leukemia for over 10 years now, which seems crazy. We've been working with blinatumomab for a long time. But these new players have come on the scene in the last year and a half to 2 years, both in the EU. I know for our European colleagues, we have a very similar treatment landscape in terms of what's approved for use. So in lymphoma, we have epcoritamab, glofitamab, and mosunetuzumab. You can see all three of these agents have the same tumor-specific antigen of CD20. In myeloma, we have several bispecific antibodies that are approved for use as well, with a different, landscape of tumor-specific antigens. But excited to talk about these three in the middle for treatment of lymphoma. So again, just kind of separating these three products into what they are approved for. We have three products for lymphoma that are CD20 by CD3 bispecific antibodies. Mosunetuzumab is approved currently for relapse or refractory follicular lymphoma. And then in the large B-cell lymphoma space, we have two products that are approved for use both in the EU and the US, epcoritamab and glofitamab. So we're going to be talking about these three products for the rest of the presentation. So let's get started with Mosun. This is approved, like I said, for relapse refractory follicular lymphoma, and after patients have failed 2 prior lines of therapy or more. It's available as an intravenous infusion that's given over 2 to 4 hours. That infusion duration is longer up front while patients are completing the step-up dosing, and then luckily goes down to 2 hours later on in the step-up dosing schema. So what do I mean by step-up dosing? This is a common CRS mitigation strategy that we see across bispecific antibodies. You'll see this type of schema in all 3 products we're going to be talking about today. And basically what that means is we start with a low dose and we slowly escalate the dose over a period of a few weeks to hopefully mitigate the types of toxicities that we see commonly with bispecific antibodies. So in the case of mosunetuzumab, we have a weekly step-up dosing, day 1, 8, and 15 of every 21-day cycles. You see cycle 2, we move to a Q21-day cycle, which is very convenient for patients. And the treatment duration for mosunetuzumab is actually finite. So if patients achieve a complete remission by 8 cycles, then they're actually done with this treatment. If patients have a partial response or stable disease at 8 cycles, they can continue for another 9 cycles for a total of 17. Just in terms of some labeling and regulatory requirements for the package label, there's no hospitalization that's recommended or required for mosunetuzumab during this step-up dosing. Briefly looking at some data that supported mosunetuzumab's approval for relapse or refractory follicular lymphoma. It was studied in a phase 2 single-arm study of 90 patients, relatively healthy, ECOG 0 to 1, but heavily pretreated, so median 3 prior lines of therapy. Some of these patients had had a prior transplant, but very low amount of patients had had prior CAR T, of course. For mosunetuzumab, again, we went over the step-up dosing schema, but it's there for your reference as well. Very promising response rates in this trial. Complete remission was achieved by 60% of patients in this study. The overall response rate up to 80%. A relatively quick time to CR, that's 3 months for this product. Seeing partial responses even faster. At least at the last update that we had, which was a median follow-up of 37 months, so about several years there, 3 years, the median PFS was 24 months. So really long duration of remission for those who achieve it. The median time to next treatment was similar, 37.3 months, so about as long as we were following those patients. In terms of adverse effects, this is a big portion of what we're going to be talking about today, are the toxicities. So we'll go over these in more detail in a few slides, but all grade adverse effects, the most common adverse effect was cytokine release syndrome, or CRS, in 44% of patients. But you can see for grade 3 or higher AEs, it's actually not CRS, it's other things. So neutropenia was pretty common. 27% of patients had grade 3 or higher neutropenia, and grade 3 or higher infections were experienced by about 15% of patients with mosunetuzumab. We'll talk a little bit more later again about CRS and why this data on this slide is so important, but I think it's important to kind of take away from this slide that the CRS was relatively common, again, all grades 44%, but the incidence of high-grade toxicity was low. So grade 3 or higher, you're seeing very, very low numbers there. Low amount of patients required tocilizumab or anti-cytokine therapy. Low percentage of patients required any hospitalization for toxicity. And then on the right side of the screen, you can see a little bit more about the timing. When do these patients experience this cytokine release syndrome? And you can see it's a little bit different depending on where they are in that step-up dosing. So the first dose, pretty fast, 5 hours. The most common time for CRS to occur with mosunetuzumab is actually a little bit later in the dosing ramp up, and that usually occurs about a day after the patient receives the dose. So important to keep that in mind when we talk later about implementing these products and educating our patients about when to look for signs and symptoms. All right, we're going to switch gears a little bit and talk about epcoritamab, which is approved for diffuse large B-cell lymphoma after 2 or more prior lines of therapy. It also has a PDUFA date here in the US for relapsed or refractory follicular lymphoma. So we are, kind of keeping an eye out for that as well. But currently approved for large B-cell lymphoma, and it's a sub-Q injection, so a little bit different from mosunetuzumab, a little bit more convenient for patients to get a sub-Q injection instead of sitting in the chair for several hours. Again, I kind of alluded to this, but the step-up dosing schema is very common. We're seeing that here with epcoritamab as well. The cycle lengths are a little bit different, Q28 days. But the most important things to kind of point out about epcoritamab in terms of what makes it unique are the fact that its treatment duration is indefinite. So you can see that patients continue epcoritamab until disease progression or unacceptable toxicity. And then the other thing I want to point out to you is that patients are recommended to take post-dose corticosteroids for 3 days following all the step-up doses in cycle 1. So for 3 days after day 1, for 3 days after day 8, 15, and 22. So a lot of steroids as that CRS mitigation strategy for epcoritamab. And then the other thing that's been a big topic of conversation for us in our practice And maybe for you as well, I know that the European label also has this hospitalization that's recommended for 24 hours following cycle 1, day 15. That's the time at which patients are most likely to experience toxicities like CRS. And so the label does recommend currently for patients to be hospitalized to monitor for that toxicity. Looking at the phase 1/2 for epcoritamab, this is called EPCORE NHL-1. This was a single-arm study of 157 patients, a relatively large study, and relatively healthy, again, ECOG 0 to 2, heavily pretreated though, median 3 prior lines of therapy for these patients. We're seeing a decent cohort in this study of patients who had prior CAR T. 40% of these patients had prior CAR T exposure. This was really exciting for us to see so that we could have a little bit of preliminary data, at least on sequencing. Can patients respond to bispecifics after CAR T or even after transplant? So I'm very glad to see these patient populations represented in EPCORE NHL-1. We discussed the dosing strategy already. This is a subcutaneous injection that's given in a step-up dosing strategy, weekly for the first few cycles, then bi-weekly, and luckily goes to monthly thereafter because it is an indefinite treatment. So luckily, patients are only having to come in once a month once they get to that 10th cycle. Very good response rates here. The overall response rate in this study was 63%, with almost 40% of patients achieving complete remission. Similar median time to complete remission that we saw with mosunetuzumab and follicular, about 3 months. These data are constantly changing. Every ASH or ASCO or updates are presented. But the most recent one we have is a median follow-up of 10.7 months, and the PFS was 4.4 months. And then we do have some overall survival data that's starting to mature. Median follow-up of 20 months, and the median OS was 18.5 months at the most recent update. So we continue to watch for longer term data for these products, but this is what we have for now. In EPCORE NHL-1, I do want to point out the toxicity of epcoritamab, CRS being, of course, the key AE of interest. It occurred in about half of patients. So 51% all-grade CRS for epcoritamab, pretty decently high all-grade incidence of infection as well at 45%. ICANS, or immune effector cell associated neurotoxicity syndrome, we're going to be talking a little bit more about slides, but the all-grade ICANS incidence was around 6%. When looking at high-grade toxicities, those that were grade 3 or more, we're seeing infection kind of predominant here at 15%. And I'll show you next CRS. So we always want to talk about CRS severity and onset. So here we're seeing, again, low-grade 3 incidence of CRS. 2.5% of patients experience grade 3 CRS. And the percentage of patients who receive tocilizumab or corticosteroids beyond those that were prescribed as pre-meds or as those post-dose steroids are listed here for you as well. So coin flip, if your patient's going to experience CRS, right, the incidence was 50%, but very low likelihood that that toxicity is high grade. In terms of time to onset and duration, the time to onset, the median is 20 hours. So again, about the day after the patient receives the dose is when we would be looking out for CRS the most. And duration is listed there for you as well, pretty short. 2 to 3 days is kind of what we see for all of these bispecific antibodies. Next, we have glofitamab. This is the third of the 3 bispecific antibodies that are approved for relapsed or refractory non-Hodgkin lymphoma. Glofitamab is approved for large cell lymphoma, so it is in the same indication as epcoritamab. It is an IV infusion, similar to the mosunetuzumab that we spoke about earlier. The infusion duration kind of depends on how far into the ramp up we are, but ranges from 2 to 4 hours. The kind of unique thing about glofitamab in terms of CRS mitigation is this pre-treatment obinutuzumab. This is, as we all know, an anti-CD20 monoclonal antibody. that is given 7 days before the patient actually starts glofitamab to try to deplete B cells in the periphery and in the tissues, again, as a CRS mitigation strategy. So it's 1 gram of obinutuzumab intravenously as a pretreatment, and then 7 days later, we start this step-up dosing schema for glofitamab. These are Q21 day cycles. It is finite treatment duration, so that's great to see. 12 cycles of every 3 weeks is what patients receive when they receive glofitamab. This hospitalization that's recommended, again, is the current label right now. 24 hours hospitalization is recommended after the cycle 1 day 8 dose. That's when we are most likely to see CRS for glofitamab, so that's why the label recommends that we admit patients for 24 hours to monitor them for cytokine release syndrome. Looking at the phase 2 single-arm study for glofitamab in relapsed or refractory large cell lymphoma, this included 154 patients. We're seeing very similar patient populations that you saw with epcoritamab, heavily pretreated, healthy patients. Nice cohort here of prior CAR-T and prior transplant as well. So great to see some sequencing data here as well. Very similar CR rates, again, that we were seeing previously of about 40% of patients achieving the primary endpoint of complete remission. The objective response rate in this study was 52%. A relatively quicker median time to CR of 1.4 months. Median PFS, very similar to epcoritamab, in this case, 4.9 months. And the median follow-up is a little bit shorter. So 12.6 months was the most recent published median follow-up, and the median OS at that time was 11.5 months. So again, we continue to await more updates and longer-term data, but we're seeing very promising response rates to these products in heavily pretreated patients with a very difficult to treat relapsed refractory lymphoma. In terms of all grade and grade 3 or higher adverse events for glofitamab, the all grade CRS incidence was 63%, so numerically a little bit higher than what we saw for epcoritamab. Patients are still experiencing hematologic toxicities and infections, so that's kind of a common theme that we should be taking away from this, is that we need to watch patients closely for neutropenia and for infections, especially, these higher grade infections occurring about at a rate of 15% for almost all these products. And CRS and ICANS, high grade CRS and ICANS, very, very low incidence here of 3 and 4%. I want to give you this data for glofitamab as well in terms of how severe CRS is and when it occurs. Very, very low rates of high-grade CRS, 3% grade 3, 1% did experience grade 4 CRS, but a decently low percentage of patients receiving anti-cytokines or receiving steroids in this trial. The median time to onset of CRS is a little bit faster. Again, we see that most commonly on cycle 1 day 8, and that's when the hospitalization is recommended, but it's occurring at a median onset of 13.5 hours and lasting that typical, 2 days-ish. So taking away these toxicities, just want to kind of point out that the time to onset does differ slightly between products, but generally speaking is pretty predictable. I have a summary slide here, mostly for your reference, of the 3 products that we went over, kind of their route, their CRS mitigation strategy, if that's unique to that product, the treatment duration, and the indication for the product. So again, these are the 3 that we spoke about. And then also as a reference for you, I have some efficacy data in this summary slide in terms of overall response rates that we're seeing with these products, the median PFS, as well as some toxicity data that's helpful for us to keep in mind: the CRS incidence, how many patients are experiencing high-grade toxicities like infection and cytokine release syndrome, and keeping that in the context of their indication as well. So I've been referring to these toxicities. I want to go into them with a little bit more detail, and specifically looking at the acute toxicities, those that occur within the first cycle of treatment. CRS, or cytokine release syndrome, is a constellation of symptoms that we're probably all pretty familiar with, but include things like fever, hypotension, hypoxia, organ dysfunction. This is a hyperinflammatory state, and we're seeing the manifestations of that hyperinflammatory state in these descriptions. Immune effector cell-associated neurotoxicity syndrome, which is thankfully shortened as ICANS, is also a constellation of symptoms. Things like headache and delirium and expressive aphasia are the most common manifestations of ICANS, but we do see some other signs and symptoms as well, like dysgraphia, tremor, lethargy, even things that more serious like seizure and coma can occur with ICANS. These two toxicities are not just seen with bispecifics. We, of course, see them with CAR T as well. And so we'll talk about how centers that have had experience with these toxicities through providing CAR T cell therapy may be more equipped to monitor for and treat these when they occur, rather than, you know, an institution or a practice that doesn't have experience managing these toxicities with other patients in the past. Briefly, I want to reference you to the ASTCT grading for these toxicities. So for CRS, we're looking at 3 main criteria: temperature, whether the patient has hypotension, and whether or not the patient has hypoxia. These are, this ASTCT criteria is one that we use for CAR T as well, and we use for bispecifics also. So we grade CRS based on the most severe component of this. And I have some definitions for you at the bottom, but we're seeing, again, with bispecifics, very low incidence of high-grade toxicity. Most patients just have a fever. Most patients have grade 1 CRS only. So that helps us kind of put that into context of how we manage this toxicity. In terms of grading ICANS, again, referencing you to the ASTCT grading criteria, there's an ICE score that we have patients perform basic tasks to grade their neurologic status. And then the rest of these are relatively straightforward. Again, we're grading based on the most severe component of the ICANS grading. And again, we're seeing very, very low rates of ICANS overall with bispecifics, but I do want to at least have this for completeness for this presentation. So let's talk a little bit about implementing these products. We've talked about their efficacy and safety data. How do we actually give these products to patients? This figure is from a recent publication in Blood from a multidisciplinary, multi-center group that was publishing consensus guidelines for all of us. How do we manage these toxicities? How do we implement bispecifics? So I will reference you to those if you are still struggling with some of these components, like I think all of us are. But this has a nice little treatment schema, a little journey of a patient, starting with patient selection. Are we assessing patients correctly for being good candidates for bispecific antibodies? And then patient education comes next. I'll share a little bit more about our experience with patient education in a few slides. Patient receives the drug either in the inpatient or outpatient setting. There's monitoring that's required once patients receive the dose. And so these consensus guidelines do give a little bit of insight into how they recommend monitoring patients. If toxicities occur, that's the next part of this little journey. We have to decide how to manage that, right? So CRS and neurotox management are another big sticking point. When these products got approved and we looked at their package labeling, there was recommendations on how to grade toxicity, but not really how to manage it. So, and ASTCT also doesn't have great concrete recommendations for how to manage these toxicities. So a lot of institutions were kind of struggling and scrambling to decide how they were going to manage these toxicities. So we'll talk about that in a moment as well. But there are some recommendations from this Blood paper that we're going to be talking about. So implementing sounds great, right? We have these new exciting products. I've listed here just the tip of the iceberg in some clinical and logistical challenges to implementing bispecific antibodies. These are certainly considerations that we had in our practice when we were first starting out looking at these products and bringing them to our patients. And I want to go through some of these in more detail so that we can have a nice discussion and maybe some helpful Q&A at the end. But first, just to briefly kind of orient you to these buckets, these challenges. The first one being regulatory requirements and package labeling. The second being your institutional resources. How much infrastructure, how many FTEs do you have to dedicate to this project, this implementation? The next is site of care and care coordination. We have a lot of patients coming in and out, inpatient, outpatient, wanting to get some of their treatment locally, wanting to get some of their treatment transferred. Giving products that are associated with unique toxicities makes site of care and care coordination even more challenging. One of the big things that we've talked about in our practice, and I'm sure you have as well, is educating. So not only do we have to educate staff, but we also have to educate our patients and our caregivers, and explaining things like CRS and neurotoxicity are a little bit abstract, and making sure that we have patients empowered to alert us when these things occur is really important. Monitoring requirements for the products can sort of differ depending on which disease we're talking about and which product we're talking about, but making sure patients, again, are equipped and empowered to monitor themselves, and that we keep a close enough eye on our patients during that step-up period is really important. Next, we have toxicity management guidelines and escalating care. So if these toxicities occur, how are we going to manage them? Where do patients go if they need higher levels of care, even things like intensive care? If they live far away from your center or far away from higher levels of care, that may be a consideration that we need to think about before we choose a patient for bispecific antibodies. And then, of course, the elephant in every room is the financial impact of these products. We have certainly spent a lot of time talking about the financial impact of these therapies. And one thing that's a little challenging right now is that long-term data, long-term survival data, and cost effectiveness data is not available. We're still waiting on long enough follow-up for cost effectiveness data and those analyses to be done. So we really don't have a lot of helpful information on the long-term financial impact of bispecific antibodies just yet. So I'm going to go through a couple of these for you all and just kind of share some of my experience and some considerations that we have talked about in our practice. In terms of regulatory requirements and the package labeling, hospitalization, again, is recommended per the label for epcoritamab and glofitamab, which can be challenging for outpatient practices. Coordinating that care, finding prescribing privileges or admitting privileges has been something I've heard from a lot of community practices that have kind of challenged them in implementing bispecific antibodies. What if we could just keep these patients outpatient? There are no REMS requirements. There's no actual ramifications for keeping patients outpatient. It's just a recommendation, but we have to be able to do that safely. So how do we make sure we can monitor them safely in the outpatient setting is a big point of contention. And then specifically for us in the United States, in terms of hospitalization, we're always trying to maximize reimbursement and minimize financial loss. So if we can avoid having to admit someone, we usually save money doing that. In terms of institutional resources and infrastructure, specifically some things that I'm thinking about here are who's on your team, which members of the multidisciplinary team are responsible for ensuring that patients are monitored appropriately, that follow-up is done at a timely manner. During that high risk of toxicity period, those first few weeks, those first few doses, who's checking in on the patient, and how do we ensure that we have enough staff that are well-trained to do this? And certainly at our institution, we realized we think we need additional personnel. We think we have enough enough justification to add institutional resources and add institutional infrastructure to help keep our patients safe while they're receiving these products. So I'd be interested to hear if this has been a common thing for others as well. In terms of site of care and care coordination, I kind of alluded to this. At our practice, being an academic medical center, we co-manage a lot of patients with community practices, those in more rural areas where patients, receive a lot of their care locally. A lot of local community practices are not implementing or administering bispecific antibodies here in the United States. A lot of these challenges that I'm discussing today have made it really, really challenging for those practices. We're, hopeful and working with each other to try to get these products to patients no matter where they live. But the reality is right now it's really challenging for patients to be safely treated in rural communities. How do we ensure smooth transitions of care between inpatient and outpatient? That's certainly been a big topic of discussion as well here. In terms of educating staff, who's responsible for this comprehensive education? And how do we ensure that education is accurate and up to date when staff is turning over, right? Providers and staff turn over at large centers all the time. And keeping up with educating everyone that needs that education can be really challenging. We've come up with some handouts and in-service and other things that still don't seem completely adequate. So that's certainly a challenge. And then in terms of patient and caregiver education, this product requires a lot of confidence in the patient and the caregiver to understand their treatment, to understand how to monitor for adverse effects, and to alert their healthcare team when they're experiencing toxicity. So, we've developed institutional handouts and resources for our patients to assist with that education. One thing that I think would be really, really nice and helpful are non-branded educational videos or other types of multimedia education for patients to try to consume to empower them to understand things like CRS and neurotoxicity. But we certainly have worked to streamline education for these products. Next, I want to talk about monitoring requirements. So monitoring for CRS and ICANS is done in a lot of different ways. Some practices are doing this outpatient, some practices are admitting patients to the hospital where monitoring is obviously a lot easier. One thing I'd like to share with you guys in the next couple slides are ways that we can leverage the electronic medical record to help us monitor for toxicities and grade them and figure out how to manage them. So I'll be sharing a little bit in the next slide, but monitoring requirements are probably one of the biggest components for all of us to keep in mind. So like I was alluding to, perhaps we can leverage the electronic medical record to help us. This slide shows two examples from the electronic medical record. The one on the left is just a communication within a treatment plan, within a set of orders that has the patient's baseline blood pressure. We talk about hypotension as being this big component of CRS grading. And of course, we want to know what a patient's baseline is, but we don't want people to have to be searching through the chart through a ton of set of vitals. So we actually have embedded this in our treatment plan for bispecific antibodies so that everyone can see what the patient's baseline vitals are. On the right side of the screen, you're seeing a flow sheet within the electronic medical record helping us assess for ICANS. So it actually has that ICE score, that ICE assessment embedded in the medical record where whoever's responsible for documenting this, whether that be a nurse or an advanced practice provider or a physician, they can document the ICE score directly in the chart with a timestamp. So we're seeing this patient, luckily, has an ICE score of 10. Their baseline is 10, which is great. We're not seeing any signs of ICANS for this patient. But this is a way that we can leverage the EMR in our favor and really has been helpful to us. The next example is for cytokine release syndrome. grading, and even management. So the top part of the screen that you're seeing are CRS symptoms. So you can see that that is all the 3 components that we just spoke about. So fever, hypotension, and hypoxia are there. Is the patient requiring any supportive care for hypotension or hypoxia? Are they having a fever? We can actually, enter these components into this grading system. And then actually in this case, this links to the ASTCT consensus grading, as well as a treatment algorithm. So in this case, we're seeing a patient with grade 2 CRS, but the EMR has been leveraged to help simplify whoever the provider is that's doing this, or the bedside nurse, whoever's assessing this patient. It takes out a lot of the guesswork in grading the toxicity. Beyond monitoring, of course, we have to manage toxicities if they occur. So what about your institution? Do you have specific guidelines on monitoring for and managing CRS and ICANS? Who's in charge of updating those policies and procedures? How are you ensuring that those policies and procedures are accessible by everyone who may need them? Not just the nurse or the advanced practice provider or physician or pharmacist who's in the clinic, but what about those in the emergency department, for example? If a patient shows up to the ED or the ER, how do we ensure that those staff are appropriately looking out for these toxicities? And then escalating care is incredibly important. This is another thing that community practices have really expressed as a challenge for them. Where will patients present if a higher level of care is needed? And how do we ensure that facility is equipped to recognize these toxicities? I want to go back to the consensus guidelines briefly. This is the paper that was published in Blood, that multidisciplinary, multi-center consensus guideline. This is really, really helpful. If your institution is still sort of considering what to implement for toxicity management, I encourage you to go to this reference. Really, really helpful recommendations. Concrete recommendations for grade 1, grade 2, grade 3, and grade 4 CRS. And actually in this scenario, I want to just briefly point out that for grade CRS, which is the most common grade that we see with all of these bispecifics and lymphoma, this group actually recommended keeping patients at home and only having them present to the health system if they had unstable vitals, certainly if they had any signs of neurotoxicity, concurrent with that CRS. But if it's just a fever, no other symptoms, this group recommended acetaminophen, antipyretic, and oral hydration, and checking those vital signs more frequently, and considering steroids if patients continue to fever despite an antipyretic and oral hydration. But again, continuing to keep patients out of the hospital for low-grade toxicity is what is recommended here. And I think this reference is really, really helpful for all of us as we continue to assess our own institutional guidelines. A little bit more EMR support for us. We have embedded anti-cytokine therapies, tocilizumab, into order sets so that regardless of the staff member that's in charge of ordering these, that the correct dose is given. So we do have some order sets and order panels to help guide clinicians to the right dose and product. And then finally, this last consideration I just wanted to touch on briefly is the financial impact. Here at our institution, we have a formal process for adding products to our formulary, allowing patients to access certain products. And how should we evaluate bispecifics? How can we fully evaluate their financial impact as we don't have a lot of cost effectiveness data? This is a really big challenge, and I know our finance department has been particularly perked up when we talk about bispecifics here, just based on the cost of the treatment and the cost of managing toxicity. So they've certainly been working closely with our clinical staff on implementing these products. I want to leave you with a few conclusions and some takeaways. The first are that bispecific antibodies are associated with really promising high response rates in patients with heavily pretreated relapsed and refractory non-Hodgkin lymphomas. They represent an off-the-shelf alternative to or therapeutic option after CAR T. Successful CRS mitigation strategies and clear procedures for toxicity monitoring and toxicity management are really key to safely implementing bispecific antibodies. And finally, you can see several ways that pharmacists are equipped to contribute to successfully implementing bispecific antibodies. I know for us, some ways that we have contributed to implementation are things like comprehensive education, both to our providers and our patients, helping develop those toxicity management procedures and policies and algorithms, and also helping to contribute to streamlined care coordination and making sure these patients are followed appropriately throughout this high-risk period, especially at the beginning of their treatment. I would love to take any questions and generate some discussion with all of you now, and really excited to hear from the audience.
Awesome. Thank you so much for that really comprehensive overview, Sarah. I think it was fantastic. So yeah, please enter some questions in the Q&A if you have them. A couple questions I had, Sarah, are can you share what some of your experience has been with trying to implement these in the outpatient setting?
Yeah, so I alluded to this a little bit. We're obviously trying to keep patients out of the hospital as much as possible. We want them to be able to stay at home. We want to save them money and us hospital beds. So of course, that's the goal, is to get these products exclusively outpatient. Our experience has been a little bit challenging. We are currently still hospitalizing patients under an observation status per the package labeling. So where it says that you are supposed to hospitalize patients for 24 hours, we're bringing them to the hospital, but putting them under an observation status. So hopefully, that admission doesn't roll into that diagnosis-related group DRG payment. The hospital thinks that's an attractive option to help us minimize financial loss. Patients have been really receptive to that, but I do think there are opportunities for us to keep them outpatient completely. Some ways that we're working through that are leveraging our personnel and our resources. So again, we kind of talked a little bit about the median time to onset being like 1 to 2 days. Maybe you follow patients really closely during that 1 to 2 days, and you have telehealth visits or phone calls. I know for outpatient CAR T, you guys sometimes use a lot of wearable devices for patients to monitor their vital signs. With how many patients we have eligible for these products, wearable devices have not really been feasible. So it's more about empowering the patient to monitor their vitals as much as they can themselves, making sure they have a thermometer at home, making sure their caregiver is well equipped to watch out for these things as well. So in terms of implementing these in the outpatient setting, I think there are a couple things we have to, check off before we do that. One is that we select the right patients. We have patients that are appropriate, they can monitor themselves, they have a good caregiver, they're reliable. The next is institutionally, when and how are we going to monitor them? So right now we're talking through some options of telehealth visits, monitoring them through phone calls or telehealth, video chat during that high risk period, 1 to 2 days after their dose, and then not admitting them at all. The other part to keeping patients outpatient is what I alluded to a little bit with the consensus guidelines, and that is, can you manage grade 1 CRS at home? That's challenging for a lot of our clinicians and physicians to be okay with, especially when they primarily are giving CAR T, where high-grade toxicity is a little bit more common than what we're seeing with bispecifics. So people are a little squirrely about keeping patients outpatient for CRS management, but perhaps we can be a little bit more lenient and manage more patients with Tylenol or dexamethasone at home, and keep those patients just with grade 1 CRS out unless they have persistent symptoms.
Yeah, for sure. I think this is something a lot of people are trying to figure out how to operationalize. And there's a lot of different kind of unique challenges that, even if you have an outpatient CAR T program, they don't necessarily have the exact same principles that can apply across both. So yeah, I think it's something a lot of people are working on figuring out. So a couple questions here related to kind of management of toxicity. So one is about use of steroids. So does use of post-dose steroids as CRS mitigation change how you then manage CRS once it develops? And how would you guide your providers, again, with using kind of different products and different CRS strategies? And then with that, there was another question about, is tocilizumab used in the same way with bispecifics in managing CRS as it is with CAR T, or do you feel like it's kind of different?
Yeah, those are great questions. Um, One thing I didn't really talk about too much is we've seen a really big difference in how institutions and how practices manage these toxicities based on whether they have CAR T experience or not. So it's challenging for people to separate CAR T and bispecifics in their minds and in their management. But in terms of tocilizumab and anti-cytokines, I do think we are, in the lymphoma world, not CAR T, but just for bispecifics, we're using tocilizumab a little less, at least is my perception, my experience. We can, again, manage a lot of these patients outpatient. We can manage them with things like steroids. And so I don't think we necessarily jump to tocilizumab as quickly as we may for CRS, or for CAR T, where we know that CRS may progress relatively quickly. So I do think we are seeing less tocilizumab use in bispecific CRS management than we do for CAR T. It works the same way. You certainly could use it in the same way. And if your institution just needs to have a management algorithm and you have one for CAR T, it's very reasonable. We used our CAR T toxicity management policy and procedure and sort of amended it when bispecifics came. So that's how we leveraged our experience with CAR T, but sort of adapted it to this new product class where CRS may not be as severe. So yes, I think tocilizumab use is less. We're not reaching for it quite as much. But that brings up the first question that you asked about steroids. If you've already sort of played your card with steroids, can you just continue to give steroids for someone who's fevering? That's really challenging. We've had that discussion here. Epcoritamab has that dexamethasone days 2, 3, 4, 9, 10, 11. CRS is most likely to occur when the patient's already taking post-dose corticosteroids. So what else do you have? You could give them antipyretics, right? But if they're fevering through dexamethasone, then it makes you a little bit less confident in Tylenol taking care of your problems. So I do think it does change your CRS management strategy, and it probably should. We are, in our practice, admitting patients for CRS, especially if they've already taken corticosteroids at home as per the package labeling for epcoritamab. They come in to manage and monitor for CRS, and we may still give them only steroids inpatient. But the monitoring is more appropriate and quicker. I know a lot of institutions, though, have added glofitamab as their CD20, CD3 bispecific for large cell lymphoma of choice. So remember, for glofitamab, they're getting obinutuzumab as the CRS mitigation strategy and no post-dose corticosteroids. So for institutions that use glofitamab preferentially or exclusively, they're probably using steroids to their advantage a lot to manage CRS, and I think that's very appropriate. So it's interesting because I still think patients getting glofitamab are able to be managed outpatient. We have tons of practices that are doing that with steroids. So I think it is interesting that the product labeling and the CRS mitigation strategies impact your management.
Yeah, absolutely. It is interesting. And I'm wondering, does that impact your use of tocilizumab? Are you more inclined to use tocilizumab in a patient who's already received steroids, or do you feel like, steroids are kind of the bigger gun, quote unquote, so tocilizumab may not provide extra benefit? I'm just curious your thoughts on that.
Yeah, that's a good question. To be honest, we've not needed it. We really have seen in practice what we saw in the trial, which is that grade 3 and higher CRS is incredibly rare. And we often don't need to jump to things like tocilizumab unless patients progress to higher grades of CRS. So in your example, if they're, if they're already on steroids and they're fevering or they have grade 1 to 2 CRS, I think we would still watch that patient because the stats are in our favor that they continue to stay at a grade 1 or grade 2. We can watch them closely. In most cases, in our experience, it's resolved and the patient doesn't have to get TOCI and doesn't have to stay in the hospital, which is great. So I think it's all based on the grade of CRS that you're seeing in front of you, regardless of what they've gotten previously.
Thank you. And I think this is definitely calls out why pharmacists are so integral in terms of kind of making some of these policies and guidelines, because there is a lot more nuance in how you manage these toxicities compared to even CAR T, for example, especially across different products here.
Yeah.
Do you think there's any major differences in terms of outpatient management for bispecifics as compared to CAR T, specifically looking at the number of days that we need to be monitoring these patients? So obviously, CAR Ts have REMS programs that say they have to be, monitored daily for, X number of days. They have to be close to the treatment center for the first 28 days. We don't necessarily have those same, REMS requirements with bispecifics. So what do you feel is kind of the appropriate management for how long to monitor these bispecific patients outpatient?
That's a great question. We've modeled a lot of our practices and our approach after CAR T because the precedent is there and it's really, really helpful to kind of build off of. But again, I think that the products are so different that we can manage things a little bit more leniently when we're talking about bispecific. So I do think, living or staying within close proximity of a treatment center that can monitor and manage CRS quickly is really important. So, I think for us, about an hour is kind of our radius. Can you get here within an hour? If you can't, you're too far away. And I would say that the duration of that is probably the first cycle. So if it's a 21-day cycle, we want you here for the first 3 weeks. If your cycle in your step-up dosing lasts for 4 weeks, we probably want you within that proximity for 4 weeks. What's unfortunate is that, the time to onset is 1 to 2 days. So days 3 to 4 to 7, patients are like, I want to go home. Can I go home? The real answer is probably, right? We're not seeing a lot of toxicity that occurs outside of the standard deviations, but the reality is not everyone fits the trial data, not everyone fits the median. Of course, that's the whole point of estimates. So we've kind of stuck with patients need to stay here while they're ramping up. If you're within the ramp up dosing strategy, cycle 1, let's say, you need to be close to the center. In terms of daily visits or not, again, we modeled our approach early on after CAR T where we were doing daily visits. I think that might be a little overkill for bispecifics based on what we're hearing from these consensus guidelines, the incidence of toxicity that we're seeing. I think daily visits might be a little overkill, but perhaps a happy medium between the CAR T approach of daily visits and just letting patients, off the hook, let's say, is maybe a telehealth. Maybe that's a nice compromise, is that we don't make patients come in and get labs every single day, but at least there's a phone call or a telehealth visit where we can lay eyes on someone and their caregiver and say, how are things going? Do the checklist, have patients, telling us what's going on and making sure that they're good to go and knowing who to call if things happen after hours. I think that's another thing we haven't really talked about too much, but making sure patients know who to call and making sure the person who answers that phone call is equipped to tell them what to do is also a really important part of this.
Yeah, absolutely. I think those are really great points to think about. And then really quickly in our last minute, if you can give just a brief overview of how you manage cytopenias with the bispecifics and whether or not you reduce the dose or potentially even stop treatment based off of ANC.
That's a great question. Our general approach is to use the product's label. And if there are recommendations on grade 3 or 4 hematologic toxicities interrupting your treatment, we would follow those. I wouldn't recommend or say that we recommend changing the dose typically to mitigate cytopenias or manage those, we're just delaying treatment. So maybe you're delaying treatment until the ANC recovers. The other thing that we saw in the trials and in these consensus guidelines is the use of growth factor to keep patients on treatment. There are a decent amount of patients who are going to need growth factor to press on. So especially if you're in one of these products that has a finite treatment duration, you just need to get patients through 8 3-week cycles. I'd use growth factor to your advantage. Like, let's put them on growth factor. Let's keep them on schedule if you can. We know the median time to a complete response is 3 months. So if you're already seeing cytopenias during that period where we're really trying to get patients into a remission so that they have a chance of durable response, I would be using growth factor very quickly. If it's later on in therapy, maybe they're on an indefinite treatment and you're really still struggling with cytopenias, then certainly, backing off the frequency is something that we commonly see in package labeling to help us manage that. And I would follow the package labeling for interrupting treatment, but I certainly would recommend using growth factor to your advantage.
Awesome. That's fantastic and really helpful. Thank you so much, Sarah, for such a great presentation. Really valuable, and appreciate your time. Thank you,
Awesome.
everyone, for attending.
Katie, and thanks to everyone in the audience. Appreciate you.